Hello, hello, this is Professor White, and this lecture is on dialysis. Dialysis, as we know it, is a technique in which we move blood through a semi-permeable membrane into a diacylate solution. So dialysis, we call it diacylate. And that corrects the fluid and electrolyte imbalances, removes the waste products, and we are able to return the blood back to the patient. So as a reminder, as we go through this lecture, we will be using next-gen thinking, including recognizing and analyzing cues, which is information in the past medical history, considering the patient and their values, analyzing more the clinical picture. Relevant diagnostics has a place here a little bit. Prioritizing hypothesis, which would be the most pressing priorities in this procedure and the patient who has dialysis. Generating solutions and taking action. These are the skills, procedures, collaboration, teaching, and ethical concern, and then of course medications to know. All right, so let's get started here. I like this picture for you guys because it says who needs dialysis. So indeed, who does need dialysis? We can fix acid-base problems, so that's one reason. Electrolyte, especially that pesky potassium. If that gets too high, we're going to need dialysis to get rid of it. Intoxications, including drug overdoses. If there are too many fluids on board, so the patient cannot filter because, and as a result, they cannot get the fluid off. And then, of course, uremic symptoms. So uremic is the buildup of the waste products. Specifically, that would be like our creatinine and our BUN, creatinine 9. Look at me not spelling. Okay, so we're going to move on over to our next section. Now, this is a little bit different because unlike an actual medical condition, we're dealing with a procedure and a patient who has been undergoing dialysis or needs dialysis. So we're going to break this down just a little bit differently on this one, just so we can get a good understanding of it. So recognizing and analyzing cues, instead we're going to talk about the types of dialysis. And that's going to give us basically what we need to know. So there are basically 3 different types. Okay, so the first type of dialysis that we are going to discuss is what you know as hemodialysis. So hemodialysis is the one that we traditionally think of when we think of dialysis patients. This is the one where the person has to have some sort of vascular access to give high blood flow. So it's a very high velocity blood flow. So high velocity flow, this is the one that we think of because they go to the dialysis center. They're done as an outpatient generally. They go 3 to 4 hours. 3 times a week. So it's a pretty big lifestyle commitment to hemodialysis. So we'll talk a little bit more under generating solutions, how we set patients up for that and things like that. So that's hemodialysis, the number 1. The second type of dialysis that we're going to be familiar with is peritoneal dialysis. So peritoneal dialysis is the one in which we have the abdomen and we have the fluid and we have the basically flow into the abdomen and then flow out of the abdomen. And basically it's a 3-step process for those folks in which we are first dwelling, or I'm sorry, inflow. So that's considered inflow when it goes in. And then as it stays here, that's considered the dwell. And then drain, D-R-A-I-N. And what they are draining is something called effluent, E-F effluent. So if you see that, that's what they're talking about. They're talking about the drainage out of peritoneal dialysis. And then the third type that we have is something called continuous renal replacement therapy. So CRRT for short. And this type of dialysis is done for AKI. It's not done for end-stage renal disease. It's for acute kidney injury. And this is the one that the person is in the ICU. And still requires vascular access, but generally through the temporary vascular access, which we'll discuss. And this one mimics the kidney function. So it mimics the real kidney function. So this is 24 hours at a time that it's done, basically a very, very slow exchange so that there's a decreased risk of blood loss. Compare that to something like hemodialysis where we have high velocity flow. There's always the risk for blood loss and changes and pressure, and we often deal with some hypotension. So under continuous renal replacement therapy, it's for the patients who couldn't really take care of having so much velocity, so much flow changes in their blood pressure. So these patients are generally physiologically unstable. So that's why we would do that a little bit more. Another thing to know as basically differences for these are that when we have hemodialysis, the person requires heparinization, and CRRT, they also require heparin. And that is not the case with peritoneal dialysis. So we need heparinized blood with hemodialysis and CRRT. Another sort of difference between these types of dialysis is that hemodialysis and CRRT don't really cause loss of protein. However, peritoneal dialysis absolutely does. So protein loss, which can lead to malnutrition in the patient. So those are little things to sort of remember about those. And the other difference is, of course, CRRT is ICU. This is outpatient. And then this is done at home, generally speaking. Okay. As far as relevant diagnostics for the patient who is undergoing dialysis, no matter basically what type of dialysis, we always want to monitor the kidney function. So we need to look at their BUN, creatinine, GFR. Because of the potential protein issue, we want to check albumin and prealbumin because those let us know our nutritional status. And as far as that, I mean, I think that's pretty much a lot of the actual labs. Now, if we were to think about getting vascular access for our patients that need dialysis, we might do vein mapping, things of that nature, but that's for a different lecture, I guess. So I've moved us over to prioritize hypothesis because I do think we need to talk about the problems that can occur with dialysis. And of course, if we don't do dialysis at all, the person will continue to be uremic and they will eventually die from the uremia. But peritoneal dialysis, okay, so doing it, of course, is through the abdomen. So it's a surgical procedure. So this can be a problem. So whether or not people want to have the surgical procedure or not. But when we do peritoneal dialysis, we know the biggest and most threatening thing to happen to a patient would be peritonitis, which can lead to overwhelming infection sepsis, and then, of course, they could die. So there's that. So we'll have to look at how we can assist with that. And then, of course, we have the malnutrition issue with the protein loss. Hemodialysis, some of the biggest concerns that we would have occur during dialysis, so hypotension, blood loss. Hypotension would be like a big priority, so we can star that, like get star peritonitis. So hypotension, blood loss, which may or may not be related to the hypotension. Mostly the hypotension, though, is caused by shifts in the fluid and just moving the blood too fast out of the person's body and through the machine. We have risk of infection, and not just regular infection, but also Hep B and Hep C. It's said that up to 10% of dialysis patients are positive for hepatitis C. And then, of course, based on the underlying pathophysiology, cardiovascular disease, somebody who's on end-stage dialysis, end-stage renal disease with dialysis, they have a very, very high mortality rate yearly, so we want to keep that in mind. And then CRRT, again, there's not as many changes in the blood pressure. This is meant for people who are in ICU, don't need a dialysis nurse to do it, but the patient is critically ill when they're undergoing this. It's saved just for them. We had a lot of patients during COVID that we were doing CRRT on, and we still will. And as far as problems as well, infection could come over here as well. And that's because with some of the access ports that we have, so hemodialysis can be done through an AV fistula, an AV graft, or a temporary access. Sometimes we call that a Shiley. CRRT is generally done through the temporary vascular access. And peritoneal, of course, is done through that special catheter that is placed in the abdomen. Look at me not spelling tonight. How funny. Let's try that again. That's how you know I'm a real person doing this stuff. So catheter, peritoneal dialysis catheter. So remember, we're at this point we're having something in the person's body, so we always have an increased risk of infection. With the peritoneal dialysis, though, we're placing fluids and such right into the peritoneal cavity, and we could just be putting tons of bacteria in there if we're not careful. Okay, we're going to move over here to start discussing some of the nursing care of the patient, as well as some of the assessments and things that we need to know. So we're going to start with hemodialysis, I think. So we'll put that as HD, which you'll often see as hemodialysis. The person is in need of vascular access to do this exchange. So the preferred is the arteriovenous fistula, or AVF. In this, the surgeon takes an artery and a vein and basically sews them together. And this basically allows the vein to become thicker walled. It becomes larger, but you can't use it right away. Whoops, why is that moving on me? You can't use that right away. It takes up to 6 months to be truly mature, so several months till mature. And then the other thing is that the person really has to have really good veins, and most of our patients who need dialysis chronically don't, because they have diabetes, hypertension, vascular issues, so they're not usually candidates for the AVF. So they'll often have what we call an arteriovenous graft. So that's the graft. And this is synthetic. So the provider is basically going to take an artery and take a vein. And as a result of that, let's see, let's say we'll put the artery right here. Look at us being all crafty. And the vein. And basically, they have a synthetic material that would kind of mix the two. All right, so if it's a fistula, they just sew those together and let the arterial blood go into the vein, and if they don't have that, then they graft it. So that is the AV graft. AV graft is mature usually within about 4 weeks or so, so it's a little faster. And then, of course, we have the temporary access. For some folks, if they keep losing their fistula or something like that, then their temporary access really is quite long term. But that is usually placed, well, for real temporary would be the internal jugular, the femoral. For some of these folks, we have them tunneled, and you'll see them in their chest and going that way, so they're not straight in the neck. So they'll tunnel from below instead of above. So we would say basically the internal jugular or the femoral. Femoral is in a straight up emergency. We don't like to use femoral lines a lot for pretty much anything unless we really need to because of the risk for infection. Look what's nearby, the toilet. All right, so one of the things that can happen for a person with an AV fistula or an AV graft is something called Steele syndrome. We always need to be on the lookout for that. Whoops, here comes this thing again. Messing up with me. So Steele syndrome, like I'm stealing something. So what am I stealing? In this case, you would be stealing the arterial supply distal to the graft or the shunt. So what would that look like with Steele syndrome? And this is why it's important to have the assessment, is that it might look like increased cap refill times, so greater than 3 seconds, so that's not what we would want. It could look like numbness, tingling, pain. Basically, signs of ischemia distal to the graft. Now I'm going to erase that just so I have a little bit more room to write, should we need to write here. So I have a smaller space than you do. So Steele syndrome is something we need to look for, so we do need to assess the patient distal to the graft. The other thing is that we need to do pretty constant assessments on this. So we want to be checking the bruit and the thrill. We hear the bruit and feel the thrill. So these sounds and what you're feeling is basically because of the very fast blood flow of the arterial blood in the venous area. So hear the bruit and feel the thrill. You can put your stethoscope on it and you'll hear it, and if you touch it, sometimes it's almost like a buzzing. It's very, very turbulent, so that's a bruit and a thrill. And another one of the things that could happen during hemodialysis is something called dialysis disequilibrium syndrome. So that's something that the book talks about and might be important to note. This can happen during dialysis or after, so it could be when the patient returns to you. But basically, the person will have a complaint of a change in their mental status. So that's a good assessment piece for us for a person post-dialysis, is to make sure that they are at their baseline so that they don't have any brain swelling or increased intracranial pressure. All right, some other complications, of course, from dialysis is we talked about hypotension. So priority nursing responsibility under hypotension, of course, is to monitor their blood pressures. And also, as we're about to send patients to dialysis, we have to understand that we're about to move a lot of blood in and out, and that can be a really big issue. So you definitely want to pay attention to the meds that they're on. Are they on antihypertensives before dialysis? We often will not give them. So when you're not sure what to do, hold these meds. So hold the antihypertensives, hold their ACEs and ARBs, hold their beta blockers, hold their calcium channel blockers, hold their diuretics, hold their vasodilators, so things like nitro. We want to make sure that we do not allow the patient to become hypotensive during the treatment. So hold those BP meds on dialysis days. We do get a lot of rapid responses at my work, and they're often called in dialysis because the person has gone completely hypotensive and passed out, right? So hold their BP meds. And then understand that if you give certain meds before a person goes to dialysis, they might just be washed out. So a lot of our antibiotics are dialyzed out. Digoxin is a medication that is dialyzed out. Some of our vitamins. So for our patients who are going to dialysis and we have those meds to give, we may want to just give them when they come back. And I wanted to draw an actual kind of synthetic loop fistula there. So anyways, as we're going on, so constant assessments on the dialysis. We want to make sure that the patient is stable to go to dialysis, including their weight and their vital signs, listening to their heart sounds, their lung sounds, and then repeating the process after it's done. And just going back to the dialysis disequilibrium, again, the priority findings would be restlessness and disorientation. So dialysis disequilibrium. It's an emergency, right? Restless and disoriented, vomiting, headache, these are signs of increased intracranial pressure. So it could lead to death. So this is an emergency. We need to stop or slow down. That was an exclamation point. Stop or slow down the dialysis. Get that provider involved right away. So this is danger, danger. Okay, so that's a lot about the actual process of dialysis. And now we're going to talk about peritoneal dialysis. So I guess I can add it right down here for us, peritoneal. We said the biggest complication that we're going to have with peritoneal dialysis is going to be infection, peritonitis. So we need to assess the patient for those potential signs of peritonitis. So what does that look like? Any thoughts? That looks like they may have pain, including rebound tenderness of the abdomen. Why did I put a question mark there? Well, getting tired. All right. Cloudy effluent. So how does a person know that the effluent is cloudy? Sometimes we can't always see it. And your text message mentions having them take the effluent drainage bag and place it over something like reading material and see if you could see it clearly, and if not, it could be cloudy. And if that's the case, the patient is going to need antibiotics. So cloudy effluent, pain, rebound, tenderness, of course, fevers, things like that, any sign of infection. So peritoneal infection, what else? They could be at risk for hernias, so that's due to increased intra-abdominal pressure, so hernias. They might need to have the hernias repaired. And if that's the case, then we would want to decrease the amount of fluid that's being brought into their abdomen. Lower back pain can occur. And as a result of that, we may need to give them braces, and maybe they need PT for strengthening. Let's talk about blood in the effluent. So bloody effluent. This can be perfectly normal for a person if the dialysis catheter is newly implanted, so there might be just a small amount of bleeding in the abdomen. It's also normal with menstruation and ovulation. So you want to make sure if that's happening, the patient calls with it, we want to find out, is it possible they're ovulating? Are they having their menses? However, if it is new or persists over several days, then they could be bleeding. So we need to look at them closer and get them in for assessment. And then, of course, the protein loss and potential malnutrition with peritoneal dialysis. As far as generating solutions and taking actions with the continuous renal replacement therapy, outside of mentioning that, again, it's an ICU level of care, doesn't need to be done in dialysis, and is for our physiologically unstable patients because it doesn't lead them to have too many drops in their blood pressure. The nurse that's doing it is continuously monitoring their fluid and electrolyte status and making sure that things are adjusted so that the person does well. I want to take a special moment here to talk about hepatitis, right? So hepatitis, we don't have a vaccine for hepatitis C, but hepatitis we do. And patients who are getting dialysis do need to have the hepatitis B vaccine. Okay, and of course, to make sure that we're on the up and up with our technique and not, sharing anything in between, even by accident. All right, so let's recap. Hemodialysis has the fistula. You have to hear the bruit, feel the thrill. It requires high volumes of blood flow, which can lead to hypotension. It can lead to cramps. It can lead to all sorts of problems with the patient. They may have Steele syndrome from the graft, and they may have dialysis disequilibrium. Peritoneal, big risk of infection. We need an absolutely sterile procedure to help prevent this. We talked about the signs and symptoms and some of the other problems, hernias and low back pain and bloody effluent, and then the need for vaccines for our patients on hemodialysis. All right, I want to take just a moment to really talk about the care of the patient with an AV graft as well. This is under nursing care. And you probably already know this, because you guys are so smart, but I'm just going to write it down so that there's no problem, right? No BPs, no IV access, no venipuncture in the affected side. Understand that the AV fistula, or the graft, is the lifeline for the patient. And If a person comes back from dialysis, understand that they're using large, large needles into that AV fistula and graft. The person could bleed. And if they bleed, pressure, right? You know that. Add pressure. Apply pressure, and if you can't get it controlled, they may need to go to the hospital. Unfortunate where I work, the last time we had this happen where somebody just started bleeding from their fistula, the dialysis nurses actually have a clamp that can go over it and really hold everything down. So that is always a possibility. Be on the lookout. Okay, so in going through the text and some of the other resources that I review and putting these lectures together, I brought up a few medications that you really should know to take care of a patient with dialysis. And of course, the first one was erythropoietin, Epigen, Procrit. Those are the other names for it. This, as we know, the kidneys make this. This is a hormone. Erythropoietin is a hormone that stimulates the production of red blood cells. So if our kidneys are not functioning, then we'll need to replace that. So erythropoietin is given for red blood cell production. Understand that sometimes we can have too much of a good thing, so we do not want to give erythropoietin, at least in NCLEX land, if the hemoglobin is over 12, I believe. Go check your text for sure, but definitely erythropoietin cannot be given if our hemoglobin is already high enough. Okay, so next medication that we want to look at is calcium carbonate. So class of meds is we have phosphate binders. The most common one is calcium carbonate. You may see some others like Renvela, but for us this is a phosphate binder. Is this one of the problems in dialysis with the fluid and electrolytes is too much phosphate, not enough calcium. So if we give the calcium carbonate, binds phosphate, it's a twofer, right? So it's a good thing. So we don't give phosphate binders with other meds. We generally give it before meals. And then K-exalate. K-exalate for treatment of hyperkalemia. So this is the one that's given basically by mouth through the GI tract. So little reminders about anything we give GI, especially this, where it will pull the potassium in from the bowel. If the bowels aren't working, this would not be the best med to give. And we've discussed before, but one of the things we can do that is not to do with the bowels and need GI is to give regular insulin IV to push those potassium into the cells. So we're not excreting it, we're pushing into the cells. Gives us a chance to correct it. So those are the meds that I for sure was pretty good at looking at in our textbook. And now I do want to bring up one more thing as we go here at the end of this lecture, and that's to deal with diet. So our renal dialysis diet. People on dialysis do need dietitian involvement. In general, we want low sodium, low phosphate, low protein diets, right? The person needs to have adequate protein, but we don't want to overdo it, especially our peritoneal dialysis patients. So the other thing is that that we absolutely need to have good quality protein. my pen's not going to work right now, so we'll just talk about it. Right? We want to have high quality protein. So this is because high quality protein produces less waste, which would have to be removed during dialysis. So high quality protein comes from meat, poultry, fish, and eggs. All right, we want to avoid high fats. We don't want salt substitutes because those are high in potassium. So we want to hold down the potassium, make sure we have adequate protein, and definitely you could look at potential renal diets as a definite NCLEX test item. And if it's an NCLEX test item, these are often highly tested in classrooms and things like that. So what are some things you can teach the patient? No sodium, so no canned or processed foods. Avoid the salt substitutes. Avoid the bananas, etc., avocado, carrots, all those items, tomatoes. And that their protein should be high quality protein. So they're not going to get it from their red meats and things like that. We're going to get, again, from meat, like poultry, fish, and eggs. Those would be excellent sources of protein. Okay, so I guess that's where we'll mostly stop here. And I guess that's that. Have a good night, or day, if it's day when you're listening to this.